How was everybody's Thanksgiving, by the way? You studied, right? That was good. I had a good one. I was in New Orleans for Thanksgiving this year with one of my friends. It was pretty sweet. We went and saw Battle of the Bands and the Bayou Classic football game. It was fun. A little different experience, but I'm definitely going to go back next year. All right, so today we have two short lectures. One's going to be on kind of introduction to the more emergent parts of pulmonology, respiratory failure and distress. This will be, again, a lot of these you'll be learning further about these when we talk about emergency med in senior semester. The other lecture we have today is on vents. So those are two short ones. So we either get done early or we will potentially start talking about neoplasms. All right, so we'll go through these. You guys have ortho Friday?
Yep.
Okay. I'm not going to spend a lot of time on these slides. A lot of this is just definitions. The concepts that I want you to really understand are, when we talk about respiratory failure, we've already talked about the anatomy, we've talked about the function of the airway, we've talked about the function of the parenchyma of the lungs, the alveoli, the oxygenation, the ventilation, the respiration. So when we say the respiratory system has failed, that means we either don't have sufficient oxygenation, right? This is kind of some examples. We'll talk about this ARDS, acute respiratory distress syndrome, where again the lungs turn into giant sponges and then cannot perform that function of exchanging oxygen for carbon dioxide. Pneumonias, atelectasis, where the part of the lung collapses. So again, we're talking about the functional part of the lung, the parenchyma, cannot perform its function and can perform that function of oxygenating the blood. And then some reasons that we have insufficient ventilation, again, we can't vent off that carbon dioxide. These are more of moving air, the physics of moving air. Either we've got obstruction in that airway, we're not breathing fast enough to get that oxygen or to get that carbon dioxide out, and then some other chest wall problems. Something's wrong with the neuromuscular system, or a patient is very obese and they just have that obesity hypoventilation. So definitions, again, you don't have enough oxygen in the blood, or you have too much carbon dioxide in the blood. And so this is really what happens in hypercapnic respiratory failure. So this is where we can't vent off that CO2. Normally in peripheral tissues, hemoglobin gives up the oxygen and takes the CO2, and then it reverses in the lungs. So with hypercapnic respiratory failure, you've got that carbon dioxide retention, and remember what happens when the PCO2 goes up, that drops the pH, gives it a right shift, and so we're decreasing the ability for new oxygen to get picked up in the lungs. So there's less available to the tissues. Again, at the end, we create cellular hypoxia because the effect the CO2 has on the pH gives it that right shift, and so it doesn't pick that oxygen up as efficiently. So it's a little bit more direct when we're talking about the hypoxemic respiratory failure, and it's a little bit more indirect when we talk about how these things can lead to respiratory failure as well. It's just a little farther down in the chain, but both of them lead to cellular hypoxia, right? Tissues are not getting enough oxygen, and when that happens, tissues begin to die. So when you're not getting enough oxygenated blood, all of those fun biochemistry concepts that we learned in sophomore semester cannot produce enough ATP, and those organs begin to die. That's why when we have somebody not we go BLS, right? BLS, the first thing we want to do is perfuse. We want to give them oxygen, and we want to perfuse it, because the longer the body goes without oxygen, the more tissue death that we experience. So everything we do in BLS is really to maintain that circulation, maintain that airway. Those are two critical functions in order for the body to function properly. All right, so distress versus failure. So it's a continuum, obviously. It's kind of like when we talk about asthma attacks. Respiratory distress, someone becomes a little more agitated, they're breathing really fast. Again, we talked about this early. When the respiratory system starts to fail, you see it translated clinically very quickly. This is not something where someone can go days and things are building up, building up, building up. Someone's in liver failure, but it takes them a week, right? Because we gotta wait for all those toxins to build up. If someone goes into respiratory failure and there is a problem, your body wants you to know and react to that quickly. So you will become tachypnic. You will become agitated. People's heart rate will start to go up. All of a sudden, every sensor in your body is saying, we're not getting enough oxygen. Alert, alert. Let's start breathing faster. Let's start pumping blood faster. That translates to, I'm anxious, I'm agitated, I need to get myself out of whatever situation is causing this. And then in our case, that's our job, right? Figure out what's causing it. And these are kind of the effects of that oxygen dropping. These are the kind of the effects of that CO2 starting to build up, and then these translate into our clinical exam findings, right? Or our subjective or objective findings. So then, got the respiratory coming up. But as someone moves into failure, instead of tachycardia, they start to have bradycardia. Because the longer this goes on, right, the longer it goes without oxygen, that affects the function of the organ. And so it's trying to beat, 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 beat as it starts to run out of oxygen. And those tissues simply cannot produce that ATP, and they cannot as effectively become tachycardic. So you'll see bradycardia, you'll see hypotension, and then obviously cessation of breathing, and then the body starts to lose, and you'll be able to see it physically. Not only through the vital signs, but also obviously the patient's general appearance, mental status. They will be cyanotic, not doing well. All right. So what do? Obviously, if you figure out what the underlying cause is, you correct it. So, patient is got a foreign body, you do the Heimlich. You unobstruct that airway. And then you provide support. We're going to give we'll talk about giving oxygen, but that is going to be a huge part of that. That is something that we can do, support that, because sometimes it's not possible to completely reverse it, right? Someone may be in a COPD exacerbation, we've got to give them time for those antibiotics to set in. But in the meantime, in order to maximize that delivery of oxygen to the tissues, even though we're starting on antibiotics, we're starting them on steroids, over that next 48 to 72 hours, we want to make sure that we're keeping their SATs in an acceptable range, maximize that. So oxygen support, sometimes patients need to be intubated. So this is obviously not a complete list. Anytime they lose that patency, again, we talked about thermal burns and somebody's airway swelling shut, or they have some sort of allergic reaction. We want to maintain that patency of the airway, because obviously, if they lose patency of the area, they're going to have a mixture of hypoxia. You know, they're not going to be able to get the air in, and they're not going to be able to get the air out. So that one's a really very quick transition from respiratory distress to failure. All right, so you're giving them oxygen, but they're not responding. So we'll talk about how intubating and mechanically ventilating someone improves the delivery of O2. And then sometimes patients, I actually intubated someone on the floor in the hospital once because her mental status declined so rapidly, unable to protect the airway. So while we were trying to figure out what it was, the decision was made, we need to protect that person's airway so they don't lose it. And it ended up being too many payments. Oh, there we go. And then COPD, again. So these are just some reasons that patients go into respiratory failure. COPD and asthma, they don't require intubation, they have a pretty good outcome. Again, sedatives, opiates, that's another very common reason. Patients have respiratory distress and go into respiratory failure. That's why everybody gets Narcan now when you get opiates. And then we'll talk about ARDS, especially the one associated with sepsis. This is why patients end up admitted to the ICU. This is the thing that we're worried about. So if someone comes in, they've got a pneumonia, bilateral pneumonia. If they're at high risk, we want to have these patients in the ICU because the ICU is the best place for patients who we suspect are going to develop acute respiratory distress syndrome. We'll talk about that right now. All right, so this concept, it's kind of an umbrella term. We talked about interstitial lung disease. This is kind of an umbrella term as well. There's lots of different reasons patients go into acute respiratory distress. Or why they develop this syndrome. This kind of explains what happens, and this is one of the key words here. This is a non-cardiogenic form of pulmonary edema. So if we say non-cardiogenic pulmonary edema, this does not respond to Lasix. So if you have someone that's got acute congestive heart failure and they develop pulmonary edema from that, you can give them Lasix. You can decrease the volume, and that will reverse the respiratory symptoms. These do not follow that. These are, patients that have pneumonia, very commonly patients that have sepsis. And we'll talk about up here what happens to the lungs and why this develops from things like aspiration. We talked about aspiration of gastric contents. I think we touched on this in one of our lectures earlier. So what happens is the lungs become injured. So that is one of the critical criteria. So by definition, something happened within a week. Why do we say a week? Because it's like, we put our thumb out and we looked at all the patients that went into acute respiratory distress, all the patients that developed this. We went back, we determined that in all cases, patients had some sort of insult, whether it was a pneumonia, whether they aspirated gastric contents, whether they were in a fire, right? They were goofing around, huffing stuff with their friends. No one ever did that. So things that happen, so some sort of insult. Most commonly, patients will develop this within 24 hours, but by definition, it has to be within 1 week. So I keep saying what happens, my daughter says that, and I'm like, where do you get that? So what happens is, regardless of the cause, those endothelial cells and the alveolar cells become damaged. So that damage leads to increased vascular permeability, and then the lungs turn into giant sponges, and they start to suck fluid up into them, again, like they are giant sponges. We talk about neonatal respiratory distress, which Major Klein will talk about again in detail during PEDS. This is where the patient, either as an adult, for some reason they decrease their surfactant, which can occur with all these. And then without that surfactant, which is that fluid that keeps the alveoli patent, then those alveoli will also collapse. And then that will lead to, not only is there fluid replacing spaces where there should be air exchange, you also are losing some of those functional alveoli where they're literally collapsing, because in addition to increased vascular permeability, you also decrease your surfactant. And that is all in response to some injury. Something happens to the lungs. This is FYI, so just kind of in general, Talking about pulmonary edema versus acute respiratory distress syndrome. This is cardiogenic. Again, these respond to diuretics. So the lungs are normal versus increased vascular permeability over here on this side. So again, it's just giving you a different, so it's just teaching you like the difference between what happens to the lungs with acute respiratory distress versus cardiogenic pulmonary edema. The big point I want you to understand is that the non-cardiogenic, you can decrease the volume of fluid and it's not really going to make a difference the way that it would if you simply just had fluid overload and you literally just needed to diurese someone. All right. This is not something that you should try to manage as an outpatient ever. So clinically, again, depending on how sick the patient is, sometimes you have to, sometimes there are the patients that are already in the hospital, and so you know them and you're monitoring them. Sometimes it's patients that just come in and you have to get the history. They come in from, you know, they've had pneumonia for a week, they went to see the doctor. You know, have they seen the doctor recently? Have they been hospitalized? What medications are they on? Why are they on the antibiotic? Oh, they're being treated for pneumonia. Right? So you have to kind of make sure, especially a patient that's coming in and they're tachypnic, they're tachycardic, you're trying to figure out why they look like they're agitated and trying hard to breathe. Maybe their sats are low. You already know that they have pneumonia. So getting that history is very important. So if they are conscious, they are going to be very dyspneic. As those lungs start to fill up with fluid, they literally are replacing airspace with fluid. So they're going to be hypoxic, refractory, so you're going to give them O2. It's not that they're not ventilating effectively. It's not that they literally do not have functional lung parenchyma to exchange that oxygen. So no matter how much oxygen you give them, it does not, you got to fix this first. So again, we talked about that early. They'll be in a little bit of distress. Again, crackles, we're talking about fluid down in the parenchyma. So those are those alveoli snapping open. And then as they progress into from respiratory distress to respiratory failure, then they become extremely hypoxic. There's our change in mental status. There's our significant change in vital signs, right? Vital signs become significantly abnormal, i.e. mental status changes, general appearance changes, vital sign shifts, unstable. So patients become unstable. I'll show you what pictures of these look like. We talked about the pleural effusions. We talked about the fluid and how you lose those costophrenic angles. So this is going to be one of our clues for ARDS that is not a pleural effusion, because you can still see those costophrenic angles. This is not fluid outside of the lungs. These are the lungs becoming sponges. We'll show you what these air bronchograms look like. I'm sure Major Passion probably talked about these. And again, it's not a specific change. It's just that these bronchi, which are normally dark, are highlighted with fluid behind them. So the bronchi, which run all throughout the parenchyma of the lungs. So you have the bronchi, and then you have all these little branching off bronchioles and terminal bronchioles. So within that, those air-filled bronchi become highlighted. So it's just it's a contrast thing. But we call those air bronchograms. And we'll talk about the Berlin criteria in a few slides. So how we grade the severity of respiratory distress. So here's a little picture again. So there's their nice crisp costophrenic angles. These are diffuse opacities. They're bilateral. You look over here on the left side, This dark area here, that's an air bronchogram. And again, it's not an abnormal finding. It's just that that bronchi, now you can see it really clearly, because instead of tissue with a little bit of surfactant and a little bit of normal tissue fluid in there, now it's become like a sponge. So it's whited out behind it. And again, not abnormal bronchi, they just show up a little darker. So this is progression over 48 hours. I know it's kind of hard to see, but the key point here is, again, you start to suck up fluid, and eventually it sucks it up throughout the entire lung. But we keep these, I know it's kind of hard to see, but they're still there. So those costophrenic angles are still there. This is not fluid that is, blunting our costophrenic angles. This is not a pleural effusion. This is the lungs becoming sponges and sucking up fluid. You will not need to determine severity for the test. I'll just introduce these concepts, because I don't want you to memorize this. Again, just remember this. This is criteria. This is the important thing you want to remember. That one of the most important diagnostic criteria for acute respiratory distress syndrome is that something happened within the last week. I know that seems like, why is that important? But some of these critical criteria, if nothing happened to this person was otherwise healthy, then it's probably not acute respiratory distress syndrome. And just remember that when we are treating patients, most of them don't read the book, so they're not going to come in as that classic poster child. But you need to be able to communicate why someone is at risk for acute respiratory distress syndrome, because especially say we're out in the field, right? And you want to evac someone. So making sure from clinician to clinician that you are very clear on what that insult was, right? The patient was in the gas chamber and their stuff came off, right? You need to make sure that you're communicating that, because this is one of those diagnostic criteria that we need to have there in order for you to say, so I think this patient's at risk for developing acute respiratory distress syndrome. I don't want them to do it out here in the tent, please. Again, chest imaging needs to be present. You can't have a completely normal chest x-ray and say a patient has acute respiratory distress syndrome. I am not going to spend time on this. Just understand that there is a grading. I don't think it's clinically pertinent that you guys know this, because your job is going to be to identify it, see that chest x-ray, figure out that there was an insult, look at the patient's vitals, and say, I'm making a call to get this person to an emergency room or direct admit to an ICU. So, obviously, figure out what's going on. Sepsis is one of the more common reasons, not because there's something about the pathophysiology of it, just because people become septic for a lot of reasons. So it is the most common. So for example, making sure that they're on the correct antibiotics, intubating, we'll talk about intubating. You want to try to correct that atelectasis. You want to try to correct that collapse of those alveoli. So you want to give them a little, kind of like when you sigh and you pop those alveoli open. You want to recreate that with your vents. So a little bit of PEEP at the end, a little bit of positive airway pressure. You want to try to open up those alveoli that have collapsed. Again, you want to have them on the correct treatment. Make sure they're on antibiotics, treat that infection. You want to have them on the lowest tidal volume needed. Remember what tidal volume is? That's that air in, air out, that total volume of air. So just, not the vital capacity, but just that normal breathing in and out, about 500 mils usually. And then you want to give them a little O2. This prone, this was something newer after COVID that we started doing. I'd never seen that before. I think I'd worked in the ICU or in critical care, but during COVID, we realized that prone positioning actually helped with oxygenation and ventilation, even though, again, it seems counterintuitive, but having someone on their back, it's like when you deliver a baby, right? It's probably better to be like this than like this. So there was some mechanical benefit to having patients in the prone position. So we started doing that where there's a rotation now. So when you're in the ICU, that's probably something that you're going to see, which was new to me. I did not see that in my training, but COVID taught us a lot with intubated people. Unfortunately, this is one of those, again, you don't want to mess around with. Patients that develop acute respiratory distress syndrome, making sure that we've got cultures, making sure we have them on the right antibiotics, making sure those antibiotics are working, patients are intubated, everything else, we're trying to make it easier for them to breathe. And then, unfortunately, right, people that have underlying medical problems, that are elderly, so there is a high mortality rate for patients who develop this. It's not 100%, right? But it's a lot worse for patients who are not have immediate access to higher level of care, like intubation, IV antibiotics, things like that. FYI, again. You'll probably see this when you do your ICU, especially with your extended field care. And you should not be managing patients. You should be evacuating them, but the way that the military is going, we've got to be prepared to sit on patients like this. All right, so the baby stuff. So this is the same concept. So we talked about the pathophysiology of acute respiratory distress syndrome. We talked about increased vascular permeability, and we talked about decreased surfactant production. When you decrease the surfactant production, the alveoli collapse. You need that surfactant to create that negative pressure to hold those alveoli open. So when infants are born preterm, right, they don't have enough surfactant. Less than 28 weeks, about 98% will be born with this neonatal respiratory distress syndrome. Okay, inadequate surfactant, you need more inspiratory pressure to reopen those alveoli. So this is kind of the pathophysiology. You have immature lungs, and then you have alveolar collapse, diffuse atelectasis, and then you develop that edema because of the response to the alveolar collapse and diffuse atelectasis. Neutrophils cause inflammation, cause edema. So you end up with the same clinical picture, just from a different, this isn't from some sort of medical insult, medical injury to the lungs. This is because the infant was born too early and did not have enough surfactant. Major Klein will talk to you a lot about APGAR scores and things like that, so I will not belabor that. But these are patients that, again, if you have a baby born premature, and 9 out of 10 times they are going straight to the NICU and they're being intubated. The expectation is that we want to start supporting that breathing as soon as we can and let the infant prove to us that they can do it on their own. So again, less than 28 weeks, it's about 98% incidence. If you can get them to 34 weeks, it's about 10%. So much better. All right. Again, this makes sense. There's going to be low SpO2. And then, again, just like we said with ARDS, you'll have that diffuse bilateral infiltrates. Air bronchograms. You can see that one on the left side here. That nice big air bronchogram there. All right. How do you manage it? So if you If a mom is at risk for preterm delivery before that 34 weeks, then you start to give them steroids right around that 23-week mark. So OB, managing OB, high-risk OB, that's a totally different thing. You will be responsible for knowing the basics of managing a healthy pregnancy. So in general, this is not something that you will be involved with unless you self-specialize yourself to an OB/GYN clinic. Then when the baby's born, you want to give them positive airway pressure. So we can do that with kind of the little mask. And then you can give them surfactant. So if they had steroids because you anticipated it, or if you didn't anticipate it and mom went to premature labor, came in, MBA, mom's in labor, and baby's born at 25 weeks. You can give them that surfactant. You can give it by ET tube if they're intubated, or you can give it by nebulizer depending on the status of the baby. And then you want to keep doing that until they can hold their sats. Mortality is extremely low because this is fairly correctable, as long as they're in a place that has access to these interventions. All right. Oh, God, these are horrible lectures inside. I mean, they're awesome. So what time is it?
6:34.
I mean, we're all stuck there anyway, though, right?
Living the dream.
Makes me probably better to hate myself. All right, supplemental.
Oh, that's good.
All right. Supplemental rotating ventilators. Let's go through this one like super fast. All right. So I'll show you what pictures of these look like. Important thing to note here is that as you go up, you can get more oxygen into the patient. So when we talk about what's the difference between a nasal cannula and a ventilator, you can actually deliver more oxygen into the lungs if a patient is intubated. So here on room air, obviously the fraction of inspired oxygen is 21%. That's just a nerd fact, right? As we bump up now we can deliver a little more. So the fraction of oxygen now, we can get it up to about 50% with that little nasal cannula. And those we can adjust, we have our little tanks, we can go between 1 and 6 liters. So we can get that up a little bit more oxygen per inspired breath. Face mask simple, get a little bit higher. Then we've got these Venturi and Fast non-rebreather masks. So that's that one, I'll show you what that looks like, that goes over the whole face. So we can get up to 100% fraction of inspired oxygen versus room air. 21% versus a nasal cannula, which gives us 50. So when we talked about carbon monoxide poisoning, we didn't say nasal cannula, because nasal cannula can only get us up to about 50%. We want 100% fraction of inspired oxygen to displace that carbon monoxide. So that's why we said non-rebreather mask. All right, so you want to give them 100%, so put them up as high as you can go. You want to get that to 100%. And then obviously intubated, you can typically go much higher. Because we can not only deliver more FiO2, we can also make them breathe faster. We can increase the volume of air. These are our pictures, right? Everybody's seen that nasal cannula. Just make sure, guys, they go like this, not like this. I still make that mistake. You want to put them in like the little claws. You don't want to, there's nothing up there. They'll just stick against the, I've done it before. So, in like this. The hooks go down like you're pulling down. And then this nasal, this is a non-rebreather. And then our friend the vent. All right. When to supplement? We talked about COPD. COPD is a special thing. When we talk about giving someone oxygen, you're just casually in a room. You go in, you look at someone's sats, you know, you're like, let's see, they're about 86% on room air. We need to give this person oxygen. Right? They're at 90%. I think they're probably okay. They're at 89%. And let's give them a little oxygen. Right around between 80 and 90%, you need to start considering it when they drop below that. We need to think about patients' risk for hypercapnic respiratory failure. We just talked about that. So if a patient is at risk for hypercapnic respiratory failure, that means the CO2 level in their body is high, higher than it should be. So what happens with that, especially with COPD, is that it decreases the patient's respiratory drive. So if a patient is at risk for hypercapnic respiratory failure because they have COPD or they have some sort of other risk factor, right? They're an OD patient, they've got obesity hypoventilation syndrome, something like that, then we don't want to really try to push them up until they drop below 88%. This is kind of where they live. And if you try to give them too much oxygen, you actually end up shunting their respiratory drive. So the goals need to be set a little bit lower for patients that are at risk for hypercapnic respiratory failure. So usually we don't really get excited with these patients until they're less than 88%. Versus these patients, once they get below 92, now, we talked about, you know, Colonel Cola, why do you have 88 to 90% here, but here you're saying that at less than 92%, right? 85 to 91% is when we need to start considering oxygen, right? So there's always going to be this gray area. This is one chart that somebody made. If you look at another chart, it's going to be different. In general, though, if they're above 90%, then there's not necessarily anything you need to do unless there's other indications for giving them oxygen. But what I'm going to want you to understand, though, for the test, is to make sure that you are looking for these things in the patient history. Whether or not they're at risk for hypercapnic respiratory failure. So if I give you a pulse ox, we'll go over this in the review again in more detail. If I give you a pulse ox and say, you know, what intervention do you need to make, just to keep in mind that for a patient without risk for hypercapnic respiratory failure is different than one with risk. You don't supplement until they're a little bit lower. All right, so intubation and ventilation. Why? You need to give them more oxygen, right? So you gave them the nasal cannula, you gave them the non-rebreather, and they're still not maintaining their sats. Right? Suppress respiratory function, you need to breathe for them. You need to have them on a ventilator to move the air in and out because they're not breathing on their own. You need to protect their airway. So those are those two. And then for patients that maybe aren't necessarily there, but they're progressively getting worse. So patients that are going into respiratory failure, either you can't figure out what's going on, or you figured out what's going on, they're having an asthma attack, you've given them everything that you can give them, and they're still continuing to progress. That's another indication to intubate. So we've got endotracheal or oral intubation. This is not really anything that, I know we all get our stuff in our kits, but this is not something that we necessarily do regularly. In most cases, it's going to be an endotracheal. One of the keys to doing successful endotracheal intubation is that once you put it in, you verify that you're in the right spot. So there's some general rules. When we get into EMED, we're gonna have a lab on this. So we'll be able to kind of go through it all with you hands-on, you know. Even maybe not necessarily have a chest x-ray or the CO2 detector. So getting a general, I'm at about 32, I'm at about 21. Oh crap, I'm at 8, right? Definitely not in the right spot. So just a general rule. We've got these CO2 detectors. So if it's in the right place, you should be getting CO2 out of it, right? It should be ventilating. Listening, making sure you listen over the stomach. Just like I love to intubate people with NG tubes. I'm sure 1,000 people have intubated someone's esophagus before. So making sure you're not hearing things as somebody's bagging, as somebody's ventilating it. Listen over the gastrum and you can hear that air moving in and out of the gastrum. That means you're in the wrong spot. And then obviously chest x-ray is going to be our best option. So this is what it looks like. Again, next semester we're going to play with these a little bit more. You guys can, those of you that haven't handled them, see what they look like. There's obviously a cuff. You want to make sure you deflate that before you use it. Just like you want to deflate the cuff on a Foley before you take it out. It will not work if it's inflated. But you certainly want to make sure that you're testing it so that if you get that thing in, you want to make sure that there's not going to be a malfunction with inflating that. And that is obviously like a radio cake. So when you get your chest x-ray, you can actually see it. So there's the cuff, there's the tip. The rule is that you want it within 5 centimeters of that carotid. This one, technically, I'd probably advance it a little bit. If this is the chest x-ray I got. You can see this one. You see that radio opaque line there on the right? You can trace that all the way down. So this one is too deep. And usually, this is classic. When we see them placed too deep, it's usually on a pediatric patient because it's just not something people are used to doing. All right, ventilators. So complications. One is tube migration. So pro tip, every time somebody that's ventilated is moved, you recheck the tube. If they go down to get a CT, if you moved them from inside your aid station out to the launch, always, every time the patient is moved in any certain way, you want to just recheck it. Listen again, check the depth at the mouth should be 21 to 23. So always recheck. It's very easy to forget once it's in place. So always recheck it whenever you move them. Barotrauma, again, the alveoli are these little delicate sacs. You cannot put too much pressure into those or you will cause damage to them. So that's why when you have all those practices when you're bagging somebody, you know, it's not, you will cause injury to that tissue in the lungs, the parenchyma. You can actually blow them out so that you end up with air this is one of our iatrogenic causes of pneumothorax. All right, so if you vent them too much, too fast, so your rate's too high, then you can cause an alkalosis. So you're venting off too much CO2, and then vice versa. If you're underventilating, if the rate's too low, you can cause an acidosis. So too much air, so you set it too high. You have your tidal volume set at 500 mils. That might be too high for that patient. So you have to get a lot of ABGs when you have somebody intubated as well. So make sure that you're giving them the right amount of air and that you're giving them at the right rate. So whatever's going on in their lungs isn't too much ventilation. So under, CO2 staying in the body, you get acidotic. Over, CO2 is too much is getting vented off, you get alkali. Patients can become hypotensive. And then we already talked about that one. So this is not a good one. That's why we give all our trauma patients antibiotics. Crap tons of antibiotics, no matter what. If it's a trauma patient, if you've intubated the field, put your patient on antibiotics, because you are introducing probably something that is not sterile. In the ER, in the ICU, we do a pretty good job of being sterile, but out in the field we don't. All right, so here's a little picture of a tube migration, right? So we've essentially stopped ventilating that left lung. So that would result in, obviously you're gonna not hear anything when you listen, but that's gonna result in the patient probably becoming hypoxic. And then this one, we were too aggressive with our PEEP, or our tidal volume was too high, and we now have air around that mediastinum. So the 4 things that we're going to focus on, if you talk, so Mr. Kowski, he was actually a respiratory tech, so he's, I asked him if he wanted to teach this lecture, but he wasn't available. So this is probably as basic as it gets when it comes to ventilators, but these are really the 4 most important things that you want to be comfortable with if you need to manage a vent. So the first one's the tidal volume, just like we said. That's that normal eupnic volume of air with each breath. It's not maximal inspiration to maximal expiration. That's your vital capacity. This is your tidal volume. Your respiratory rate, right? We know that one. So 12 to 16 is normal, so usually start with that. The FiO2, that's that little dial on the wall, right? You set your oxygen, put it up to 100%. Usually if you have someone that's critically ill, you're always going to go to 100%. Because if there's an indication that they need oxygen supplementation, obviously go as high as you can on that FiO2. In the tanks, usually it's 1 to 6 liters, but you can get up pretty high with the ones in the hospitals. And then you've got the PEEP, and that's that little puff of air where we want to get that little bit of opening, help those alveoli open up a little bit, help to correct some of that atelectasis. Again, that PEEP, if you're giving them surfactant and it's opening up all these alveoli, you need to constantly monitor. Again, this is why we put people in the ICU. So they've got 1-to-1 or 2-to-1 where someone's always monitoring them. Because we want to make sure as we open those alveoli, we want to pull back on all those little extra things that we're doing to allow the lungs to go back to normal function. We'll talk about these real briefly on the next slide. Key concept here. If you want to affect the oxygenation using a vent, you adjust the FiO2 and you adjust the PEEP. These 2 things will affect the oxygenation, how much oxygen we're getting in and how many alveoli are available. If you want to affect the ventilation, then you adjust the tidal volume, the volume of air, and how fast they're breathing. So if you increase respiratory rate, they're going to ventilate faster. So if you get an ABG on a patient and they're acidotic, yep, turn it up a little. You want to help them vent off that a little bit. And this thing right here, there's like 1,000 memes. Like respiratory techs, they know their vents. So just are there ones that I've never met one that wasn't an expert at vent settings. That's their show. So pay attention, learn, be humble. Make friends with them, especially if you have to deal with this. All right. And so this is the assist control. So there's many different settings. There's combined settings, right? The AC that assists but also control, so it'll kick in. Allows patients to breathe on their own, and then it'll kick in if it has to. So that's one setting. And then this SIM-V, this is kind of when you're graduating a patient off of a ventilator, and you really want to synchronize better with the patient's efforts. So the patient has to work a little more, but if they've been intubated for a month, right, we need to start building that process back up. So this is what we call the SIM-V. I'm not going to get into too much more detail on that. This just goes over the advantages and disadvantages. All right. So the 8 o'clock lecture tomorrow is 30 slides. Do we want to have an hour break before a pro dev or get tomorrow's lecture done? Okay. And then what do you guys have at 10 tomorrow? Okay. And then what do you have in the afternoon? So then everyone's just going to sleep in tomorrow? I mean, I'm all about that. Get some coffee. Okay.
Win's a win.
Don't get in trouble. And be like,
Colonel, how are you?
all right, so take a break now. We'll start again at 2. We're rounding out all of our lectures with cancers. We'll talk about overview, talk about this thing called paraneoplastic syndrome, Pancoast and Horner syndrome, which are commonly associated with the pulmonary. We'll talk about a very specific topic, pulmonary nodules. It's something that you will, because we image everybody gets a chest x-ray, standard protocol when you go in the ER for anything, lots of chest CTs are getting ordered, especially in the military because we have socialized medicine and we don't have a significant number of hurdles like some private insurance companies can put on people. So you will have a lot of patients that have pulmonary nodules. Not exciting enough for a specialist to care about, but something you're going to have to follow up on. We'll talk about our primary lung cancers, other pulmonary cancers, and then cancers that metastasize to the lung. So obviously, lung cancer is a common, very, very common type of cancer. So if you look at estimated new cases, and then you look at, it leads the estimated deaths. This is 2023 US data. So, and it probably is a lot lower estimated new cases because we do a lot of screening for this, so we identify a lot of cases, right? So we've just now started doing screening for lung cancer. We'll talk about that with CT. But it's also much more treatable, breast cancer. So lung cancer is the highest in terms of deaths. All right, so smoking. I was gonna just stand up here and have a cigarette while I was getting this lecture. I was one of those jackasses. But I went to school in the 90s. I went to high school in the 90s, and that was just what you did. You stole your parents' cigarettes and you started smoking. So, most people with lung cancer have a smoking history. So every once in a while, you'll hear someone that gets lung cancer that never smoked, or had never had a significant exposure to secondhand smoke. So it's not very common, though, for someone to get lung cancer and have no history of tobacco, either exposure or smoked specifically. 30 pack year, that's kind of that big drop off or uptick. So this seems to be a magic number in terms of our data when someone has smoked. So it's a length of exposure and a volume of exposure where we start to see those cases go up dramatically. So this will be part of our criteria when we talk about screening. Again, there's other things that can play into it. Secondhand smoke, we've got other types of exposures, right? Where we talked about that mesothelioma. So that can cause primary lung cancer. It's just in the pleura, not in the parenchyma of the lungs itself. And then there's some genetic factors. And this accounts for why some heavy smokers don't get lung cancer. So although most people with lung cancer were smokers, not all smokers get lung cancer, so we know that. All right. This is one of the tricky things. This is why we've started to screen. So signs and symptoms are not extremely reliable. And when we talk about paraneoplastic syndromes, not all the time. That's why don't be afraid to get a chest x-ray. That is something that is easy to get. It's not a lot of radiation. There's not a lot of risk. But signs and symptoms are a really important indicator. You can't really rely on them. Sometimes, like our test question patients will come in perfectly, right? They'll come in perfectly. They'll have this for this many months. They'll have hemoptysis for this many months. They'll have a 30-pack year smoking history. But in real life, it's a pretty poor indicator, especially if someone's a smoker, because a lot of them have respiratory symptoms. So you have to have a clinical index of suspicion. You need to do an early workup. You need to get the chest x-ray. That's why continuity of care is so important, and why it sucks that we don't have it in the military. Because these are patients, continuity of care is you see someone for a while and you see something change in them. You notice that they're losing weight. You notice that they have decreased appetite, right? One of the biggest anecdotal indicators is patients that stop smoking. I had 2 patients within 3 months of them quitting smoking after years and years and years of smoking, diagnosed with lung cancer. It's almost like their body knew and was telling them that, literally it was like, it was their drive to live and survive finally kicked in enough that they no longer wanted to smoke. But it was usually too late, unfortunately. And we'll talk about that prognosis. Not great with lung cancer. All right. So CBC and CMP, they can help. We'll talk about the paraneoplastic syndromes. So there are some, getting annual labs can catch some of this stuff. Patients that actually come in and get seen on an annual basis. When you see patients, especially internal medicine level patients, 40, 50, 60, 70-year-olds, there's you don't want to be getting annual CMPs on a 25-year-old, but as patients get older, it is not a bad idea to start getting annual labs on them, because things will pop up. Chest x-ray, again, there's our money sign, especially if you can compare it to prior images. So serial chest x-rays, you see something new pop up, or you see something that was already there getting bigger. So chest x-ray, CT, we'll talk about when we use those, but they are not an infrequent part of workups when we talk about neoplasms. So they're going to give us better imaging, they're going to give us better information for staging, characteristics. We talked early on in our lecture about the bronchoscopy, or early on in this course about bronchoscopy. So that can be very, very helpful for staging and to make the definitive diagnosis of specifically what type of cancer it is, if it's cancer, and what type. But it's hard when we're talking about these peripheral lesions, so in some cases we're going to have to do a transthoracic biopsy. So those are things that we also use. And then the fine needle aspiration. I just did ClinSkills 1 test out today, and we talked about the supraclavicular nodes, and those should really never be abnormal. You should never be able to feel those. If you feel supraclavicular lymph nodes, that is something that you need to have worked up immediately, starting with a chest x-ray. So that is something that is not normal to have. Peds will drive that one home as well. They have anything that causes lymphadenopathy and those supraclavicular lymph nodes is usually not good. So make sure you do that as part of your exam. So there it was 2 years ago. Maybe they got it and they said, hey, you had something on there, go get it followed up, and it was some urgent care or some and they just never followed up on it. But that was it Tuesday. Alright, so I once got in trouble for standing up at a town hall because the commander of my MTF was yelling because he didn't have his ORs full, right? So he only had half of his ORs full, and I stood up as the department chief of primary care in front of everybody and said, sir, if our ORs are full, that means we failed. And then I quickly read the room and realized that that was a bad thing to stand up and say. I mean, my employees loved it. They're like, man, that's awesome that you get up and say stuff and everyone's thinking it, whatever, but that was like giant target on my forehead because I kind of called him out in front of the whole room. But truly, if your ORs are filled up, if our specialists are seeing people, we failed because we failed at this. We failed at prevention. This is our job, prevention. Get people vaccinated. Get them to quit smoking. You know, when we do our OSCEs, it's like 2 preventive things, and I kind of get real sarcastic about it in my group, but truly, that's what we should be doing, especially when our patients are young and healthy. All of this cost, all the morbidity, all the mortality associated with certain things that we do, we need to really focus on preventing. So screening, this is something relatively new. I did OBC, or BOLIC, whatever you call it, with a guy who ended up being a cardiothoracic surgeon. And he was really, when I was department chief, he was like, why aren't you guys doing these CTs? Mostly because he was the one that would get the referrals. So this is something that's relatively new, but it is a USPSTF as of 2021. So patients, they have to have all 3. I will ask you a question on the test that will be like, which one of these patients needs to get a CT? So just at some point after you take your ortho test on Friday, this will be something that I want you to commit to memory for the test. So there's a patient that's not between 50 and 80, you cross them off. If there's a patient who doesn't have a 20-pack year history, cross them off. If there's a patient who is not currently smoking or quit within the past 15 years, cross them off. So those are the 3 criteria. You have to have all 3. And I would not meet criteria for a couple reasons. Not age. Alright, so quit smoking greater than 15 years ago, right? You don't have to keep screening them. So you can maybe if it's only been 5 years, you screen them for 10 years and then they haven't started smoking, you can stop. Or when people get old, right? There's a time we stop doing pap smears, there's a time we stop doing colonoscopies, there's a time, because the life expectancy, my husband's beloved grandfather actually died during colonoscopy in his early 80s. Like, why were they doing a colonoscopy in his early 80s? He didn't need it. It was just, I don't know if someone was like trying to pay for equipment or what, but he actually died during the colonoscopy. So, healthy guy. So don't, if it's not going to be beneficial, stop. But those 3 things, again, this will be an example. We'll do that on the review. Don't waste your brain right now. Paraneoplastic syndromes. A little zodiac nod here. But these are things that you can find that aren't necessarily the cancer, but might indicate possible cancer. Might indicate possible cancer. So these occur in about 10 to 20% of lung cancers. It's one of those things that really makes good clinicians good. So again, I did the clin skills head to toe physical exam for freshmen today. And as I'm watching it, I'm thinking about all this stuff that I teach about. And I'm watching, the students do the exam and not really understand that, like, man, if you do the same thing every time, you're going to catch this kind of stuff. You're going to catch nerve palsy if you do a full motor exam. So in my brain, I'm just thinking about all these, skin lesions, some just basic labs, right? You wouldn't see that, but you'd see it on a chest x-ray, right? Heavy diaphragm. Voice changes, right? A review of systems. So we're going to pick 2 of these. So these are our Pancoast in our Horner syndrome. So Pancoast tumor, it's just named, the name means where it's at. It's not, it's a tumor in the apex of the lung, and because of the location, it can cause certain symptoms. Patients who are being seen for chronic shoulder pain, they're going to PT, they've gotten 2 MRIs of their shoulder. They're completely normal. PT says, you know, the range of motion's there in the shoulder. Everything's normal with the shoulder, but this person has pain. So that is because when that tumor is up in that brachial, up here, it invades up in this brachial plexus. It impacts the phrenic nerve, right? Hits the pleura, hits the ribs. Remember we talked about in this first lecture, everything comes way up in here, up into the neck area. And so it can impact, you know, as a DO, I have so many patients that come in complaining of shoulder pain, and it ends up being that first rib because of the impact it has on that brachial plexus. And it causes pain in the arm, it causes pain to shoot up the neck. But it's not in the shoulder, it's up here in the brachial plexus. And we call that a Pancoast tumor. So it's rare, but when the tumor is in that location, it can cause these symptoms. Shoulder pain, right? Radiates up the arm, down the neck. Often misdiagnosed as some ortho problem. They end up going to PT. Everybody keeps doing shoulder MRIs, but what they really need to do is get a chest X-ray. Right? So you can see when you're doing your little palpate the arms and then check this, and you're doing all your little whatever, and you're saying I'm looking for atrophy. You can actually see atrophy in the hand. You can put the 2 hands next to each other, and you'll actually see muscle weakness in this hand. You can observe it if that tumor is big enough. Superior vena cava obstruction, again, coming right up through here. So if that tumor is invading where that blood is returning, at SVC. Oops, sorry. So you can have neck, head swelling, face swelling, neck and arm can be swollen. And then we've got this thing called Horner syndrome, where that tumor is actually pressing on that paravertebral sympathetic nerve pathway. And then you've got this triad of ptosis, meiosis, and anhidrosis. And this is what that looks like. So you've got the ptosis, anhidrosis, got the pupil meiosis, and then you can have some hand atrophy. So you can see the difference between this hand here and this hand here. So those are all signs and symptoms of tumors, not uncommonly what we call non-small cell, which we'll talk about later, but when they're located up in the apex of the lung. All right, so here's our little part of pulmonary nodules. So pulmonary nodule is, there's another term for that's coin lesion, and if we remember back to our radiology terms, the difference between a nodule and a mass is the size of it. If it's bigger than 3 centimeters, we call it a mass. If it's less than 3 centimeters, we call it a nodule. This is just general terminology. Someone might call a 4 centimeter whatever a nodule, that's fine. But in general, we're talking about things that are less than 3 centimeters. So it's usually isolated. It's by itself, obviously, if it's solitary. Usually round, there's normal tissue around it, and it's not really associated with anything else. It's not adjacent to a pneumonia, it's not adjacent to another infiltrate, it's not adjacent to some other pathology in the lung where you would assume that that is some part of the immune system reacting. So it's just sitting there by itself, solitary permanent nodule that's less than 3 centimeters. Most patients don't even know about. They're found incidentally. Someone comes in, they're checking for a broken rib, somebody fell, they're like, I have a lot of pain, they're like, we're gonna check you for a rib, it's totally unrelated. and then they get the chest x-ray and they see something on it. Most of them are benign. However, these are the things that you would consider right off the gate, right? Somebody called, my son's friend is a PA, let's call him and ask him, how about Aunt who so-and-so's nodule they found on her chest x-ray. And so the things you want to consider is how old is the patient, right? All this stuff you want to know about their history. How old are they? Have they ever smoked? Have they, do they have a history of any kind of malignancy? How big is it? Sometimes they can't tell you, and you're like, all right, well, go find out and let me know. And then while they're looking, you Google everything, right? Or call somebody else. And then the character of it. So cancer it's abnormal cells. So it usually doesn't grow in this nice, pretty, concentric. So like a mole, right? A mole, you can look at a mole on the skin and it's round, it's got clear edges, whatever. Melanoma, it's like spiculated. They're abnormal cells and they grow weird. Same thing with breast, learn about that in women's health. Spiculations, little outgrowths, croppings, that is not like what you consider like a benign thing growing in there. It's much more concerning for malignancy. And then obviously, the opposite's true. The patient's under 30. If it's small, and then those nice, smooth, well-defined, dense calcifications. The most important thing about this slide is, if you have a patient that comes to see you as follow-up, and they come in and they say, patient's here to follow up, I got a chest x-ray in the emergency room, or I got a CT in the emergency room, and they said they saw something on it. So you pull that CT up, you look at the CT, you look at the read, and the read says, 3 cm, whatever it says, right? The first thing you want to do is you want to see if there is an old image that you can compare it to. So if you look on this, right? You look on this, and you're down here, right? So a lot of this stuff, we don't even have to get into. So a lot of this stuff, if we can find something old and it hasn't changed in 2 years, then we can reassure the patient that day. We don't have to do any more imaging, we don't have to expose them to any radiation, they don't have to be all stressed out, they don't have to make poor life choices because they think they're going to die. You can tell them that day. So just look. Just look. Don't forget that if we're coming down here, right, and it's like, well, it hasn't changed or it's been stable for 2 years. Like, if we can get to this today, let's get there today. So that, first step you should do is look for an old image for comparison. It should be 100% question on this. All right. And then again, if there's no change, if you find one and there's no change for at least 2 years, again, you go back. This one was taken 3 years ago to ER, and there it is again. It's the same thing. It's the same size. It's the same read. It hasn't changed. Didn't they tell you to follow up for that? Yeah, they did, but I was busy, so good. Happy ending. Like most of these are going to be, oh my gosh, this is going to die. I'm going to have to stand up there. On the other hand, if you don't have it, then you have to make a clinical decision. Then you have to look at it. You have to look at the characteristics of what you're reading. You have to look at the patient history, any prior malignancy, look at the site. So if it has any of those high-risk characteristics, then you're going to want to send them for more advanced imaging. Usually it'll take, in most cases I would probably get the CT. If the chest x-ray looked abnormal and I was going to send them and they did have high risk of malignancy, in most cases I would order that CT, but it's fine just to refer them to pulmonology at that point if they've got any risk for malignancy. If they're not, if they're young, if it's small, if it's nice and it's, you know, central calcification, they're otherwise healthy, they're young and healthy, they've never had cancer, they've never smoked, then you need to perform these serial CT scans. So again, it'd be nice if you looked and you found an old image where you didn't have to give them a CT scan every 3 months. Go ahead. If I'm able to compare and it has changed, yeah. I mean, you could image it, but if it has changed, I would refer them. Yeah. I guess it depends on the patient, and it depends on how much it changed. But if there's any progression of it, I would at least call. Yeah, I would at least call. But if they only have a chest x-ray, and it's not, it's like 0.6 centimeters, and you're like, what kind of hole is that? If it changes, it doesn't change, then you can go ahead and get the CT in the meantime. That would be completely appropriate. Yeah, CTs are obviously better because they're going to show you this stuff a lot better. So don't be afraid to get a CT on this one, especially if you're thinking cancer, because the patient's going to be fine too. All right, these are just examples of it. Again, this is our nice solitary, nice and round, nice central calcification. It's got clear edges versus this gross thing over here where you can see these crazy spicules coming out. So no bueno. All right, lung cancers. So there's two main types of lung cancers. Really, really, really advanced medicine here. It's just based off of histology. One of them small cell, one of them non-small cell. Not very exciting. Small cell, and again, that's literally, they just differentiate it based off of what they see on the microscope. Small cell, we've got small cell carcinoma, and then we've got this, what's called combined. Essentially, this is all going to be one category when we talk about it. This differentiation of the combined is not really clinically relevant. And then we've got these three non-small cell. So adenocarcinoma is going to be the one that we're going to focus on today. All right, primary lung cancers, again, primary versus secondary. Primary initiate in the lung itself. They start in the lung. It is lung tissue that is the primary abnormality. So we've got small cell, which makes them about 15%. These are usually smokers. This is an epithelial cell cancer. And then we've got our non-small cell, which we break up into these three. By far the most common is going to be our adenocarcinoma. This is also the one that most commonly affects non-smokers. We've got squamous cell carcinoma. So again, the small cell and the squamous cell are going to be more primarily associated with smokers. And then we're going to talk about a little bit more about characteristics and how to differentiate these. This large cell carcinoma, not going to focus on that one a lot in this lecture. It's only about 10%. And then we've got this carcinoid, which is like the, if you had to get one lung cancer for carcinoid, we'll talk about why. And then we've already hit on this one. This is the pleural cancer, closely associated with asbestosis. So this is the first one. This is small cell, again called small cell based off the histology. It's small cells. It begins in the central airway. So if I give you a chest x-ray, the clue is going to be mass in the central airway, right? So it starts in the middle. It starts with those epithelial cells. Most closely associated with the smokers. It's extremely rare in non-smokers. So in most cases, and when it is in non-smokers, there's usually a strong correlation with secondhand smoke. So this is the smoke goes into the airway and causes, for a sufficient amount of time, that it causes damage to those epithelial cells. And then at some point, that damage, the body is no longer able to correct those abnormal cells, and it turns into its own thing, which is a malignancy. Again, central airway, you're going to have massive lymph node response because that damage is happening right there in that airway. So always consider in smokers with any nuance that something's different. Cough's getting worse. Now I'm coughing up blood. This one's got a higher association with that paraneoplastic. So two of them that we talked about were SIADH. Did Peter talk about that yet? And the second one is the superior vena cava obstruction, which leads to, so it backs up, that blood can't return, and then instead of backing up, when we talk about pulmonary hypertension, instead of backing up in the right side of the heart, it backs up in the body itself. So you're going to see swelling, head, neck, and arm swelling. This is an FYI, so this is again central airway. You're going to have lots of lymphadenopathy. You can have this, because of where it's at, you can actually cause some phrenic nerve palsy, and this will lead to a hemidiaphragm. So these are all clues to the underlying etiology, which is small cell carcinoma. The chest x-ray, CT, we're not going to go into very much detail when it comes to this. This is mostly an FYI slide. The only thing I would say is this is why we screen. So most patients, by the time they present with symptoms, because a lot of them are smokers, smokers just take being short of breath, cough, that's just like a day in the life, right? So by the time we catch these, by the time patients come in and they're sick enough because now they're coughing up blood, or now they're becoming anorexic, fortunately, patients that smoke are not the healthiest in the population. They don't seek regular care. So this is why we try to get them screened, because we don't want to wait until they're in advanced stages, because they are rarely amenable to resection, and even treated, it's only about a 1 to 5 year. So it's not a good cancer to be diagnosed with. Adenocarcinoma, this is the most common lung cancers. Smoking is a risk factor, but this is the one, if Chronocola says a young female non-smoker and gives you all the clues that she's got a peripheral mass, and it's going to be adenocarcinoma. But this is the one that's going to be closely associated with that. Does it mean that 65-year-old male smoker? No. So it is a risk factor. This is the one that we're going to associate with the female non-smokers. All right, so again, signs and symptoms depend on the stage. This is a little bit more, again, it's more in the periphery. You can have a lot of these, it just depends on where the tumor is. Less common to get the other paraneoplastic syndromes. And then treatment stage dependent. Again, another one. Lung cancer is not, at least these types have a high mortality. It's hard to treat them. Not only because people show up later in more advanced stages, but just because of the nature of the lung, it's hard to resect these types of cancers, just by the nature of how the lung is set up physiologically. So squamous cell, this is very similar to the small cell. It's another central, but instead of the epithelial cells, it's actually the squamous cells of the large bronchi. So hemoptysis is going to be more frequent with this one based off where it's located. Again, this will be central, so hilar adenopathy, mediastinal widening, versus with this one, it's going to be more of a peripheral tumor. Symptoms vary again. Diagnosis follows a similar path. At the end of the day, screening for this in high-risk patients, that's our job. Identifying them, talking to them about the problems with smoking, and then sending them for chest x-rays, and then referring them if we find it. That's going to be our job. This one I won't go over. This is just another one of the non-small cells, so that just rounds out the categories for us. But it's about 10% of lung cancers, primary lung cancers, and it falls in line. There's nothing very distinguishing about it, so not Not to say it's not important for the person that gets it, but as far as, you know, your brains, which must prepare for exams and hands, is probably not a high yield. There's our squamous cell. So the adenocarcinoma, if you look on the left, it's a little bit more peripheral. The squamous cell is going to be more central in small cell. So it's just a way to clinically differentiate the two. So the other ones we have, the carcinoid, again, this is the one, it's a neuroendocrine cancer. You can cut it out. It's got an amazing survival rate. So again, part of the reason it is also got a great survival rate is patients present a little earlier because they're more symptomatic. So it's in the airways, causes a little obstruction, a lot of coughing. You still get the chest x-ray, you identify it, but carcinoid tumor, as long as you can get access to care to get it excised, 90% survival rate. And then this last one, mesothelioma. So this is, again, very unique because it's one of the only pleural cancers that we have. It also affects the peritoneum. There's an association with asbestos. That's the primary association with this cancer. The exposure is typically far in the past. So we have, after we banned it around 89, then we kept people in a monitoring program. So they got annual imaging to assess for it. And the symptoms are going to be pleuritic in nature, so that take a big deep breath. As soon as that lung approximates to that inflamed or malignancy on that wall, you're going to have symptoms. You're going to feel pain. So pleuritic pain, obviously weight loss. X-ray is going to show things pleural. If you tissue biopsy or if you do the pleural effusion, give you a little hint on that one. So there might be a pleural effusion sample in there that's got some cytology on it that says mesothelial cells. So I'll stomp this again on Friday for you. All right. So again, this is this is all the cancer in the pleura. So it's going to look extremely different. All right, and things that mess with the lung, these are a lot of stuff mess with the lungs, unfortunately. So the job of you is you get a chest x-ray because someone has respiratory symptoms, you identify something, maybe you get the CT, maybe you don't, depending on what the read is. But in most cases, metastases are going to be those multifocal, right? So it almost seeds from other parts of the body. Usually it's bloodborne, but it can also go through the lymph system. So your job is not to treat them. Your job is to listen to their symptoms, determine that they need some sort of imaging or next step, referral, whatever, and get them to the level of care they need. So nothing exciting about this. I don't think I asked anything on this one. So just to say, if you see something, then consider that this is a metastatic. All right, see you guys in 20 minutes and bless you.